Thank you everyone for staying late. I'm Haytham Hamid. I'm one of the vascular surgeons in Sunderland in the UK. And thanks Evo and the organizing committee for the opportunity. So I'm going to talk about atherectomy or atherothrombectomy in aorto-iliac occlusive disease. We had from the talks today, and atherectomy and vessel prep is quite popular in femoral-popliteal disease, but it's not that common to be used in the aorto-iliac disease. I have no disclosures, but the objective was, is there any evidence for that? And then I will go through how it started in our center, how did we set up the protocols, and for that, we'll go through the outcomes and some of the learning points from the complications that we had. The background is basically, it's you got patients with acute and subacute thromboembolic occlusions where you think there is a risk of distal embolization and they are quite comorbid, so you don't want to go for open surgery for them. And also the advantage for that as well, for that approach as well will be the quick recovery and discharging those patients. So we look at the literature, and actually, there is not a lot out there. This paper is coming from China, and over 10 years, they only had 38 patients where they did a thrombectomy in aorto-iliac segment. And also in this retrospective study from France, it's a multi-center study, and they are talking about using Rotarex in general, but they only used it in 31 patients over 5 years in iliac arteries. But they had good short-term and mid-term results. So we felt, okay, that's an option. But other people, they use retrograde, use the in-stent restenosis, not occlusion, as well as occlusion, but also they use the in EVAR limbs. And that's what that is a rotational device like Rotarex or aspiration like Penumbra. What brought it to our center is learning from our events where you got a subacute or you want to stent a lesion where it's slightly subacute and no one knows what's the optimum time for it. Give or take, people leave it for 3 months, 6 months, or 8 months, but it's based on no evidence. And you go in, you wait as long as you can, and you go in and you either through the emboli proximally, occlude the other side, or thrash it distally in your access vessels, and then you have to go for open surgery. But even though if you take precautions and you do that over the wire embolectomy, and for example in this common iliac artery stent occlusion, you could lose your internal iliac artery by doing the over the wire embolectomy. However, being careful, and then you spend a lot of time trying to do aspiration from that to get it back. So we started in 2022. We had an unfit patient with high BMI. She had worsening CLTI. She had extensive tissue loss on her heel with an occluded common iliac stent. So we used Rotarex for that. It was a 10 French catheter, and we managed to get a good result out of it. So we set up a protocol thinking, well, okay, this is an option for us and we can use it again and again. And we collaborated with the company for pre-op planning, decided that the catheter size is based on the diameter of the vessel or the stent. We always did it through retrograde access. We went for a sheath size more than the catheter by 1. We used artificial flow to get some flow for the catheter to work on. We initially started relining every patient, but later on we became more selective, and we always protected the contralateral side with the balloon. We'll go back to the closure device later on, but and when to use it. And it's simple, like what you use in femoral-popliteal segment, up and down hovering maneuver. When you're coming close to the top, you inflate your balloon, contralateral balloon, to protect the other side. Don't expect a good result from the first run, but with 2-3 runs, you get a good luminal gain after that. So started publishing our experience, and we're now done 12 aorto-iliac occlusions, 9 stents and 3 natives, which, as far as we know, is at least the biggest number in the UK and potentially in most countries in Europe for a single center. Most of them were done for subacute disease. We had this normal, typical vascular demographic data for those patients. The most used catheter was the 8 French, and the sheath size actually corresponded to that. The common iliac artery was the most treated artery, but we used it in aorto-iliac and full-length iliac occlusions as well as external iliac artery. The procedure-related complications, which is the main aim for this, there were no major embolizations. We had 2 minor where they just needed aspiration through a catheter, but no major embolizations from that procedure. We had 2 perforation/ruptures, which I'm going to show them later on. The hospital stay is minimal, mostly 1 day for most of them, apart from the first case that we did who had an extensive tissue loss in terms of heel ulcer, and unfortunately she lost her leg after that. Not related to the procedure, but probably it was too late when we did it. Technical success was 100% with good midterm results, and 1 major limb amputation. 1 patient needed reintervention, and another in terms of endovascular work, and another one underwent an ABG more than a year later, and unsurprisingly that ABG as well occluded 4 weeks down the line. So she must have had a hematological disease driving that. The learning points from our mishaps included the access. They are traditionally or normally underfilled small arteries, and you're putting a big sheath on them. And so initially when we started, we used pre-closure post-style devices, but when I was here, I think around 3 years ago, I saw Evo downgraded a 12 French sheath to an 8 French sheath and then using an angio-seal. So I thought that's a good idea, and I applied the same principle for the pro-style. But I also reduced the catheter size to the same sheath size, and I found the artificial flows still going with that. And also I moved away slightly from having the same size, the catheter corresponding to the stent. If you have an 8mm stent, for example, traditionally use an 8 French catheter, but this patient had a very small common femoral artery. So we went with a 6 French catheter, but you spend more time on it, and you actually get a good result out of it. But also try, if you have any concerns, and this is the patient who had the intervention, try to find where the culprit region was. That stent went down for a reason, and IVAS is really helpful in that it will find where the problem is, and you can address it at the time. But also be careful from native arteries, especially if they are tortuous or calcifications with Rotarex, because with any minimal calcification or dissection, you might end up with a perforation. Nothing massive, just be aware of that and have a cover stent handy in the room. In case that happens, then you put your cover stent and we'll seal that. But we pushed and you get good result from it. But we tried to push it further, and we went for aorto-iliac occlusions like this patient, where the occlusion is from the level of the IMA. And when the catheters, and you get that over time, when you got the noise changed on the lights on the machine, you know there's something wrong that happened, and then you try to take the catheter out, but sometimes because of the overheat, the wire got stuck. The natural event on that, and then someone just pulled the wire and the catheter thinking, okay, we're fine. But at the same time, the anesthetist looked at us and said, look at the blood pressure is in the boots now. What's happened here? And it was 50/25. And immediately we realized it's a rupture in an occluded aorta. You don't have wire across it. And it was surprising, actually, because you expect with an occluded aorta that they won't have a lot of flow lower down, but that was a sudden drop in the blood pressure. And in a panic, the wire was pushed up and putting a balloon, which ended up in a subintimal plane probably, or extravascular, and it made the situation worse. But it got rectified quickly, and we got the wire through, we ballooned it, and we got the cover stent at the end. And we learned from that it's always have an anesthetic support handy, because you can't keep an eye on everything, even if you're doing it under local anesthetic. And if the wire gets stuck, never take your wire back. Slide your sheath all the way up. Make sure that you are across the treated area before removing the wire, because when that happens, the device is overheated for a reason, and probably you've done some damage across it. So in conclusion, there is not a lot of evidence outside there, but it is a good technique and an approach for patients with stent occlusion or native occlusion, especially in the acute and subacute phase, and will reduce your distal embolization and need for open surgery with good and medium-term results. It has a learning curve, so modify your SOP or algorithm on the way and treat it, tailor it towards the patient rather than a fixed fact. Numbers will be small, over 4 years, roughly coming to 4 years now. We've done 12 cases, and the whole multi-center study from France had around 30-something cases. So we will need more cases and multi-centers to participate to get an achievable result. Thank you.
Any questions from the audience?
Do you think you would benefit from a larger atherectomy device? Would the company look at doing this in the aorto-iliac segment rather than traditionally the femoropopliteal segment with a smaller?
No, so what they have now for Rotarex, they got 6 French, 8 French, and 10 French. They're working on a smaller version for tibial work, but the 10 French is even good for EVAR limbs. When I started doing them, I went to workshops and I asked people whether they're using it on aorto-iliac segment, and everyone said no, and they never saw a 10 French catheter because they hardly use it on the femoropopliteal segment. So I've actually learned it the other way around. I started doing it with the big catheter, which I think the 10 French is more than enough to clear things for you. The difficulty comes sometimes if you got an occlusion from the aorta to the external iliac, where a 10 French is pretty dangerous to use in the external iliac, but you need it for the aorta. And it's going to be a bit more expensive to open 2 catheters to use on both. So you have to kind of sacrifice and use the smaller catheter for the smaller artery and just spend more time in the aorta.
Thank you. I use in my daily practice bicross. It's the same conception like Rotarex, but with a low profile access. It's the maximum is 8 French delivery system. Do you have a problem with access with this big French sheet you use in this patient?
I mean, with the 10 French, yes, obviously there will be the access, but we did them all percutaneous at the end of the day. Because for the 10 French, if we upgrade it, we use the 11 French catheter sheaths to do that. Mm-hmm. And instead of, if you've got an occlusion, especially a subacute or chronic occlusion, then it's difficult to pre-deploy a prostyle through a lesion or lose your wire again after you went through.
The working sheet of the Rotarex?
The catheter itself.
Mm-hmm. The catheter.
So they got 2 sizes. They got the 80 and 135. So they got a long and short delivery. So it goes cross bifurcation everywhere you want to go. But just once you finish just deploy the prostyle after or whatever closure device and work slowly towards it. And yes, if you have a very tiny artery, then you have to downgrade. But you have the option of 6 French and 8 French if you don't want to use the 10 French. I hardly use the 10 French, but the 8 French is mostly what we use, and it works well.
Thank you very much. We finished. Thank you very much. There is coffee break or dinner. The session will be closed now.
I would like to ask the organizer about the live cases. No. So the session is closed. Thank you very much.